So in this session, we are going to see what are the events, important events on day 2 and how we react to these events. So these are the elements of nursing care on day 2 of kidney transplant. First, we need to mobilize the patient. Most of this patient will fit enough to be mobilized. So reassess whether the pain medicine he is getting is appropriate. Check and change the dressings of all the catheters. The Foley's catheter care has to be done carefully. Remove unnecessary peripheral lines. Check the weight of the patient one and sometimes even 2 times per day in 12 hours interval. Consider need for giving insulin because a significant number of them will have diabetes. Liquid diet has to be ordered for the second day. Change the surgical dressing if required. And the induction dose, if any, especially ATG, has to be checked with the doctor and given. So we'll first see how to mobilize the patient. So most patient can mobilize without any major problem. And however, if the patient is very frail or very obese, kindly mobilize only with his assistance. Do not let the patient fall down. Check supine, sitting and standing BP. This will give you a fair idea about the volume status. If there is more than 20 millimeter mercury fall between any of this posture, you have to take extra precautions in mobilizing because these patients can have a pre-syncope and rarely syncope and fall. Check the weight of the patient once daily. This is the most accurate method of knowing the volume status of the patient. Next is about the pain. The pain is maximal on the day of surgery, and usually by the next day the pain comes down a bit. Injection paracetamol is usually given 3 times 1 gram, and fentanyl is a drug of choice and can be given after informing the doctor. There is no ceiling dose for any of the pain medicine, especially fentanyl, morphine can be given without any maximal ceiling dose. If the patient is restless and in extreme pain, inform the doctor. Rarely, severe pain can be because of blood clot in the bladder or any major surgical problems. Check and change the dressings of catheter. Change all connections and IV set daily because there are many connections and disconnections you'll be making. So this is done for safety reasons. Change dressing of all central venous catheters daily. Observe the exit site for any redness or pus discharge. If it is present, inform the doctor and usually the catheter is removed. Use only transparent dressing like Tegaderm or Micropore. This prevents sweating and also the complications associated with sweating. Rarely, the catheters do not have sutures in place and can increase the risk of exit site infection and bleeding. Inform the doctor and place a suture. Next is regarding the Foley's catheter care. The most common infection in post-transplant period is urinary tract infection. Ensure the Foley's catheter is cleaned daily and is cleaned of any secretion. Secure the Foley's catheter in place. The movement in the catheter can cause injury to the urethra and increase the chance of infection. So avoid this movement by sticking a sticker. The betadine gauze is wrapped around the catheter in our hospital, and this is not a standard practice. At all times, ensure the urobag is kept above the floor and not on the floor, and it should be kept below the level of patient's bladder. If needed, you can clamp the catheter for a few minutes if the urobag has to be adjusted, especially if the toilet commode is below the level of urobag. Never disconnect the Foley's catheter and the urobag. Next, remove any unnecessary peripheral lines because any extra lines which is not of any use increases the chance of infection. Next, change the surgical dressing if the dressing is soiled or there is visible soakage. Check the weight of the patient at least once per day because weight is more accurate method of checking the intake and output balance than volume measurements. And this can be done more than once, especially if the patient has heart failure and weight management becomes a major target. Consider giving insulin, especially if the patient's blood sugar goes beyond 200 because at all times we want to keep a blood sugar of less than 200 milligram per deciliter. The most preferred drug for a patient who can eat and drink is giving tablet linagliptin. And if the blood sugar continues to be more than 200, then short-acting insulin like insulin nactroprid can be given. Liquid diet is usually given on day 2, and in select patients, uh, a solid dinner can be ordered. It can be a normal or a diabetic diet. Try to order as per the patient choices within the limits of a normal prescription of diet in kidney patients. The ATG dose usually is given on the second day. So confirm with the doctor whether there is an injection or induction medicine that is due for the day, and this can last for second and third day also. In our hospital, the protocol is to give 2 milligram per kg of thymoglobulin and is usually given in divided doses over 2 to 3 days. There are some other induction agents and those dosages can vary accordingly. Please discuss with the doctor. So 24 hours after the surgery, when the patient is able to eat, all the medications are generally can be given by mouth. However, if there is any reason patient is not able to take medicines, a IL-2 feeding needs to be considered. Thank you.